Hello, welcome everybody. Thank you for joining us today at this event from PDPAL project. We are very happy to have with us Dr. David Pedrosa, who will talk about interdisciplinary approaches for the management of Parkinson's disease. But first, let me give just a brief introduction about our project. The PDPAL project is an ongoing project focused on palliative care in Parkinson's disease. We decided to focus on this topic since PD patients have considerable and mounting unmet physical, psychosocial, and spiritual needs that needs to be addressed in the current management. We have to face several barriers and challenges in order to do that. And one of those is a linguistical one. In fact, palliative care is often understood as a synonymous of end of life or terminal care. Our overall ambition is to validate a new model of palliative care that would be easily integrated within the traditional management. Our consortium consists of 10 different partners from 7 European countries, and we're currently benefiting also from the partnership or endorsement of other European associations as well as other European projects. The objectives we are trying to reach are to draft guidelines and recommendations to understand when better referring patients to palliative care. We are also conducting a clinical study based on a nurse intervention that is allowing patients to coordinate their care, address multiple symptoms, but is also allowing them to think about disease trajectory, disease course, and express their wills. We have also developed a massive online open course to address education in palliative care. And this MOOC will be available for patient caregivers and all neurologists and healthcare professionals interested in palliative care as well as movement disorders. I want to thank again all the consortium and of course the European Commission for sustaining us, and I will just let the stage to Dr. Pedrosa. I hope you all enjoy the webinar.
All right, so thank you very much for the introduction and for framing the idea of the PDPAL project, which is one of the projects we're doing with all the partners. My name is David Pedrosa. I'm the head of the movement disorder section here at the University Hospital of Marburg. And let me just first of all introduce the whole topic with Parkinson's disease. As you all know, Parkinson's disease is a neurodegenerative disorder that affects mainly people aged 60 and older, but there are also cases, especially in genetic forms, where younger people are affected. And the problem with Parkinson's disease is the underlying pathology is some neurodegeneration, which is mainly reflected in histochemical analyses by the presence of Lewy bodies, which are basically alpha-synuclein aggregates that spread throughout the brain. And you can already see here, so these are the Braak stages, that the disease spreads from the midbrain and from the brainstem in the prodromal phases to further parts of the brain in the or further parts in the brain where the motor symptoms get obvious. And at Braak stages 5 and 6 on the right, you can see that the pathology is spreading throughout the entire brain, which makes sense like clinical sense if you look at the patients as they are developing symptoms that are not merely motor symptoms, but that are far beyond that. And if you look at current diagnostic criteria, what you have is still the motor symptoms that are the hallmark of the disease. And you have a combination of bradykinesia and rigidity, or bradykinesia and tremor, or a combination of all three symptoms, which lead to severe affection at the end and motor symptom burden. But there are also non-motor symptoms, and I'm going to refer to that in a few minutes, because today what we want to talk about is how to manage Parkinson's disease, how to alleviate symptoms for affected patients, And this includes, of course, non-motor symptoms. But let's go back to the traditional way of treating Parkinson's disease. And this is a very iconic picture you all may know. And this is Jean-Martin Charcot here on the right, with one of his patients, one of his very famous patients. It's about hysteria, which is not related to Parkinson's disease. But you may not know that Charcot was also a very important person for the description, but especially for therapies of Parkinson's disease, as he was the one who proposed that Parkinson's disease may be treated with anticholinergics, which is probably one of the first substances that have been used for Parkinson's disease. The problem with this is that we have been basically looking at Parkinson's disease patients the same way as was done in the early 19th century. So there was a physician who was supposed to prescribe some medication, to give some sort of advice, which is of course difficult because we're not trained, we're not educated to see many of the symptoms in a way that another professional could see. Which is of course outdated and of course sometimes problematic for patients, because we see them once every 2, 3, 4, 6 months, and then we get just a spotlight impression, and we cannot say what happens later. So that today, or today's modern concepts of Parkinson's disease treatment are more and more shifting to a multimodal treatment. I want to give you an example, a very clinically relevant example at our hospital and also here in Germany. And this is what we call a complex treatment, which means that we admit patients to the hospital and we treat them with different professions together. We try to get an impression of what the patient is actually suffering from, what the problems are, and we're getting a very, very broad view into what the different aspects of the disease could be, and what we could actually target as our intervention. The good thing about this treatment is that we really have regular meetings. We have a very close interaction with the different professions, and we establish a therapeutic goal. And we propose some actions that may be interesting, may be good for the patient, and so on. This is a very good example. There are also hospitals that are offering this not for inpatients, but in a way for outpatients, with a very good interaction between the professions. And it's I personally think that's the way to go. Although and like patients are very satisfied with that, like the amount of patients that are really profiting, are really telling us that this is a great way of treatment is very high. It's the majority of patients. It's almost all patients. The problem is always how to get that into the health system, because we can do as many things as we want within the hospital, but the moment people are discharged, the moment we send them back home, all this multidisciplinary approach in many cases is not pursued, and so people lose this benefit within weeks or even shorter, because we can hardly make sure that this is really also done at home or where patients are actually located. Even in the nursing care facilities, it's very difficult to get this organized. And this is highly relevant, and the government the German government has already recognized this problem of getting care services to the patients while they are at home. And like in the last 2 decades, there have been a lot of efforts towards trying to get services far beyond the inpatient care. And I want to show you some examples of what is actually possible today. And the problem with the German government, it's very difficult, and I don't want to, it certainly goes beyond the scope of this talk, but the problem is that the contracts are made with a federal institution, and there was no possibility to get direct contract between the hospitals and the care providers. And so this has been changed, and in fact, there are incentives right now, like today, there are incentives for care services to be offered directly or to be established directly between the hospitals and other parties. And there has been some liberalization, as I said, in this regard, so that it's easier to get integrated care models implemented, included, even in regional parts of Germany, where the amount of offers is restricted. Another very important aspect is this discharge management, which is mandatory since 2017, and it makes sure that we can not only do our complex therapy within the hospital, but that we can offer some guidance, that we can, of course, provide some recipes for different professions like physiotherapy, speech therapy, occupational therapy, but also neuropsychologists or psychotherapists, which is also, in my opinion, a great milestone, as this is not put in the hands of the GPs, who are, in many cases, like especially in the complex cases, they are overwhelmed by the difficulties of the disease. And another thing that I will talk later about is also the possibility to offer telemedicine solutions for patients, which is also something that gives us the opportunity to put more expertise to the treatment of patients. What are the needs in an integrated care model? This is certainly just an extract of the list, and you can think of any service that is related to non-motor symptoms. So there are many different aspects that can be addressed, and so the needs are multifaceted in Parkinson's disease. And one of the things that is actually gaining some importance in Germany is the possibility to create a network, and this network means that you organize people into some sort of structure, and that you offer some education. And what we do here in Marburg, so this is a map of Hessen, which is a region in Germany, and you can see Marburg is the big blue dot in the middle, and you can see these are cooperating practices here in Germany. So neurologists, to which we have a good contact, and I personally drive to these colleagues, and we discuss patients, and we offer some guidance if there are some open questions. We also offer the video therapy, which goes into the scope of telemedicine, and the video therapy means that we can assess patients regularly, and we can have a look at different problems. It's also something that we try to implement to our partners. And we have a homepage, which is not online right now because we are working on a new design, but the homepage is with educational material that was provided to us from the Parkinson's Foundation. We're a center of excellence in the Parkinson's Foundation. And so we received their material, which we are more than happy to offer to our partners. The whole network is is open to anyone. This is not only medical doctors, but also anyone who may offer or who offers some service to Parkinson's disease patient may be part of this network and just receives some emails, some offerings, and so on. And I want to give you an example of what integrated care could mean. So we have the network, but at the same time, we know that we, as the center with the expertise, we are the ones who must provide somehow a multi-professional approach that is for the benefit of patients. And this is a study that was conducted in Cologne, where I was before with Lars Timmermann and especially Carsten Eggers. And this study was about how can we change the standard of care for patients with Parkinson's disease. There was a very similar network back then. And what we did in this study, and this is from 2018, the results, what we did back then was to offer a multidisciplinary care. So there was a Parkinson nurse who drove to the patients We had also practices, neurological practices, who were affiliated with the neurology department, and we assigned patients either to the intervention group or to the control group, and offered them either a standard of care, so seeing the patients every 3 months, or the Parkinson nurse who went to the patients and developed an individual plan. And the benefit is clearly seen even after a short, even in short terms, like in 6 months, you have increases in quality of life. So this is the PDQ-39 at baseline, which is similar because they were randomized, well, they were stratified according to some demographics, and you can see that life quality after 6 months is significantly better for patients who were in the intervention group compared to those who received standard of care. So it does work. This was a very simple intervention. This was just establishing a very basic treatment plan, which did not include many offerings, but was just intended to give a proof of principle. And as this was working, I will come to that later. We had a different approach that we are following right now in the ICPD project. But first of all, I want to give you some data, some insight of what happens if care is disrupted. And one good example is the pandemic that we are in the middle, like that we are living or that we are having right now. And the COVID pandemic was an interesting opportunity for us to look at what care actually means and how differences in care can be well regarded before and during the pandemic. And what we did is we gave we did an interview, we did a survey on patients with Parkinson's disease, and we asked them right in the middle of the pandemic how their satisfaction with PD-related care had changed. And unsurprisingly, 90% of patients agreed that their PD-related care had dramatically dropped, or had at least dropped a bit. So they were hardly anyone was satisfied, which is of course biased to some degree, but at the same time it shows that the moment that that we have less services, that the moment that physiotherapy isn't possible, doesn't happen, occupational therapy is not there anymore. People feel like their care is reduced. So again, if you think of Charcot, we are far away from this neurologist driven approach, and we are going towards a system where you have different stakeholders that are taking care. And we even looked at the potential factors that may be important for patients perceiving their care is insufficient. And what you can see here are is the reduced model of the different questionnaires. And what you see is that aspects like education of the patients is important, of course, but especially the perceived expertise of the GP. So not the neurologist himself or herself, but the GP as the pivotal part of PD-related care is the one who is really in charge of providing a sufficient care. And another important aspect is also that the density of neurologists is important, of course, and patients who have had already the feeling before the COVID pandemic that they were insufficiently treated, those were the people who had the strongest impairment in their satisfaction with care. And one final aspect is here in the middle, the lack of confidence to access services online remotely. So telemedicine is a big opportunity for us to improve care of patients with Parkinson's disease, even in such difficult times as during the pandemic. Why is that important? Or why is it important? I said that non-motor symptoms are also very important. One thing that we are really bad at as neurologists, at least in my opinion, is to treat non-motor symptoms. This is something that we haven't been trained on, and so I think that putting a stronger emphasis on non-motor symptoms such as depression, so affective symptoms or non-motor symptoms in general, is something that we should, well, be aware of as neurologists, but that we should also contact other disciplines, our professionals, to provide the care needed, because this is highly relevant for patients and it increases quality of life. I want to give you an outlook in the last couple of slides. Apart from the PDPAL project, Michaela already mentioned that there is a partner project that we're also part of, and this is ICPD. And ICPD is just the multi-center extension of the study I was presenting to you before. So this is a study with international consortium. We have 7 centers, and we've recruited about 30 patients per center. So we have about 200 patients. And this is now, like, the data is now finally collected by the end of this year. And the intervention is very simple. What we do is we provide an individualized plan of care services. And this plan is actually very tailored and very much according to the regional properties within the different countries. It's also very distinct within the healthcare systems, but it is intended to provide multidisciplinary care for patients. And what we are trying to show is that health-related quality of life, and probably even a holistic quality of life, is improved just by having someone, a Parkinson's disease coordinator, who offers some services, or who facilitates services that are already there and that are probably experts in some aspects of the disease, to assess what the patient actually needs. I'm really looking forward to the results. They are still not there because we are analyzing the final results after 4 months of intervention. But there will be soon something to be published. And one final thing that I would like to highlight, and this is work from our group, again, within the ICPD consortium, is that we are talking about Parkinson nurses, which are, in my opinion, very important people for Parkinson's disease. I don't like the term Parkinson nurse, because it implies something that is not really true, and we prefer calling them Parkinson coordinator. But the problem we are facing right now is that there is no such thing as the Parkinson coordinator. But, and you can see that on the right, the roles of the Parkinson coordinator are very, very broad, and there are many different things that Parkinson coordinators are doing throughout different centers. And what we are right now trying to do is to operationalize this entire concept, and to get well, some sort of professionalization of Parkinson coordinators, so that we can in the future have these very special and very good educated and trained people to help our patients and to have a clearly defined role. This was a systematic review, and we are trying to implement that, or to elaborate some sort of role. And this is ongoing, and we hope to show some results anytime soon. I'm at the end of my talk for today, and I want to summarize what I've been presenting in the last few minutes. I think no one really doubts that multidisciplinary care is beneficial for patients, and that if we include other professions, other caregivers, or stakeholders of care provision, that we can actually do a lot of good. We can have a lot of good effects for our patients, and I think no one wants to go back to the times where the neurologist was the primary person and was deciding on the treatment. But there is a need that these professionals are trained, that they are educated, and that we have a solid ground on how to treat patients, because it's not as trivial as it may sound. For us, the Achilles heel is the post-hospital care, so we can do all kinds of good things here in the hospital, but the moment people are discharged, we need to have a continuation, and we need to have some sort of treatment that is followed after people are discharged from the hospital. But the good thing is that there is increasing scientific interest in the past years, and that we are right now we are seeing lots of studies that are ongoing and that may help to implement these services in the future to help our patients. I think I'm at the end of my talk, and I think there are some questions, so I'm really looking forward.
Yes, David, thank you so much for summarizing lots of good work that your team is doing nationally and internationally. And because we are together in this kind of European consortium here, then the first thing that comes into my mind when I listen to you is, of course, Germany is a very resourceful country, and there are lots of different kind of offerings. And what makes Germany very special is, again, compared, for example, to UK, is the role of nurses that has been undervalued, I suppose, historically. And nurses are empowering themselves currently, but governments are still not really noticing how important nurses' contribution in patient care is, and also this kind of nurse-led decision-making and nurses' role in coordinating of care. So it always has to be a physician. That's you can correct me, but that's the German take on this. And obviously there are less physicians, and Germany actually per capita has quite many hospital beds, and that's and that means also there is a great amount of nurses, but in the hospitals. But immediately when the transition to home takes place, people are faced with many problems, and don't know which services are at their disposal. And this is exactly what you demonstrated to us. And so other countries that maybe don't have so many resources might be asking that, what should be the first steps to take to improve the situation? And in particularly in this transition area, so that if you would build up something, if you would not try to change what is given in Germany, but if you would be in a country maybe with less resources, less offerings in hospitals, so what would be the first steps? How you would build up a system for Parkinson's patients when you would have very little resources at your disposal?
I couldn't agree more. The problem here in Germany is that we have neglected nurses, professionals. We have been very physician-centered in our care, and it doesn't make sense. There are so many aspects that are being covered by someone who has a different view, different perspective that I can hardly see. I can give you an example. There was a patient. It's not that long time ago, and this patient had DBS surgery, and after surgery he became he had a delirium. We had to take him to intensive care unit, and so I was personally a bit mad at him, I have to admit, because I thought, how can he dare? We are doing so much work on him. We are offering him such a great treatment. How can he dare? And so he discharged himself, and I sent one of my colleagues in time to talk to him. And what we found out is that he had a trauma. Like his father was being treated in a psychiatry. He was being kept there, and so when he woke up after surgery, he felt like he had the same situation. And so I was too busy to being mad at this person, of feeling of the feeling that he was ingrateful, and he wasn't ingrateful. He just had this situation, and that's an aspect I would have never asked. Like asking, so what happened? Like why was there a problem? Why did you wake up and you felt like you had been put into a cage, because that was what he felt like. And that's a great example to find out that we are not talking about replacing the physician. It's about putting a different perspective into patients' role and to have a different insight. So I think we are not giving them the credit they deserve. And for your second question, what would change? One of the problems we are facing in clinical practice is that treatment, even though it's really meant in a good way, is insufficient at some point, because the providers of care, they have very few patients that are treated, and they don't know what Parkinson's disease actually means with regular medication, with the risk of falling, all these kind of things that are important. And I think what is really easy to implement, what is really easy to do, is to be there for the care facilitators and to offer some education, some internet sources, some links. I mean, there are sources like the Parkinson's Foundation, for example. They are doing a great job for the entire community to have like diaries and information and really simple things to consider. And I think what we need to do as centers with a great expertise is to spread our ideas, our current knowledge, and to put that into the everyday life of patients. And that is very simple, and you don't need many resources. And I fully agree, Germany is very, very rich, and there are many offerings, but not everywhere. So Marburg here, like in the northern part of Marburg, there's not much, and it's very, very rural. And I was surprised how many patients were, they were literally untreated because there was no neurologist taking care of these patients. They had not seen a neurologist in years. When I first came here, I was surprised, and I was asking like the guys who were here before. I was telling them, so what is happening? Why haven't they seen any neurologists? And they were like, don't be surprised. That's just the situation. We don't have that much offering like in a big city like in Frankfurt or in Cologne. We don't have that here, and we need much more. We have to spend much more time with these patients because they are undertreated. Mm-hmm. That was a long answer. Sorry.
Yeah, but I asked also a very long question, and it is healthcare systems are complex, and I think that you draw a very nice brought a very nice example that we speak about regions. We in Europe, and we see that there are great differences between countries, but there are regional differences, and it is honestly, I have studied palliative care and palliative care offerings in different countries, and you really cannot speak about a country level palliative care. You have to always look at the region, and you might have some city very well covered, and this is also like that maybe some hospice gets money only for this 30 kilometers square kilometers around them, yeah. And immediately if you fall beyond this border, you don't have anything anymore at your disposal. Yeah. So even in studies, if we study the access to healthcare services, it is always very important to see also this rurality or isolation, to consider it as a barrier in healthcare. But you started your presentation with a very nice example from history, and you also reflected on this and said that we still tend to think like this, that the physician is the one who decides what this patient needs. But you said that we need this kind of skill, listening to a patient, telling what care they need. And you know that neurologists have very little time for listening what patients need. So I think that this also is a good example that why we need other professionals who hear then their bits and pieces, and when you come together into your interdisciplinary care discussion, then you put these pieces together, and then you actually have a picture what this patient might need, isn't it?
Yeah, it is. It's it's actually I really enjoy these meetings because it's actually sometimes it's even funny what you realize, like what you're told, like interesting aspects like biographical aspects that are important. I mentioned one important aspect, even things that are relevant for treatment. I remember one patient who was she was having this. It's a very German thing. It's like a lottery. Like you buy some small things and you have to scratch them. And so when you scratch them, then you get some numbers and you sometimes win or you lose. It's called Wearables. And so I was told that this patient, she was addicted to this Wearables. She never would have told me. And that was important because that gives you the idea that this patient may be suffering from something that is related to medication. I would have never contemplated. Like my question is always like, how do you feel? Do you have symptoms? Do you have side effects? And so people are not telling me the entire picture. And so she was telling one of my colleagues so that she was really addicted to these small Wearables and she really likes them. And she was not suffering from that, but her family was kind of suffering because they always thought so that doesn't make too much sense. And so it's a really great meeting where you find out interesting things that you are not considering, and you start to ask yourself whether this is like whether you may be doing something wrong, and maybe you should contemplate different aspects of patients' life. So that's I really enjoy these meetings. Although I must admit I'm not always there. Some colleagues are doing them many times, but when I'm there, I always find out interesting stuff.
Yeah, that is so true. And you said something which is, I think, very crucial. Also, these questions that physicians ask and this kind of communicating with patients, it is so important. And I know that German universities are very good providing medical students with communication courses, also communicating with patients who maybe do not have anymore very much time left in their lives. And I have been also part of this teaching sometimes, and it's really interesting to see how some people are so excellent in those talks and others really fail majorly. So and some what you said, that that physicians always ask that like so what is wrong with you, and then the first instinct is to say, oh, I am actually fine, and so you have to become this kind of very persistent patient also to write down really that what's wrong with you, so that you get your message through, because physicians' first reaction when you say I am fine, don't worry about me, then you don't get the treatment what you need really. So and you come out very disappointed. But now when you see the patient, then you, of course, you said you see like this kind of how you said that you see one glimpse or one in the hospital. Usually they have taken their medication, they are well, they have had already a few hours before the appointment that they are doing fine. It's not this gap where they fall when the medication doesn't work anymore. And this happens usually at home. And there are some nice examples about why actually neurologists should go and visit patients in their homes. Because you see, we have this telemedicine option, but there you also see only a certain part what patients show you. But I think Indo Subramanian has written that actually walking with patients, smelling where they live, looking at the carpets, what are in their apartment or at their floors, and so that could also give lots of impressions, and that's why my question is about this telemedicine, and it comes actually with the technological competence question, so that even if you as a neurologist cannot go to patient's home, you have a nurse maybe there. And we have this problem that quite many nurses still don't have this kind of technology skills. So how does this work? Is that an obstacle, or do you think that we are getting there, within this sense?
It's I think it's one of the like meetings with people from technology and with physicians or people like really close to patients are always funny, because you start to realize how far away both are. Like you have to create a system that is easy to handle, that is modern, but at the same time that is so easy to handle that it may not fail, because we have, in many cases, we have people who are really, really old-fashioned, like patients, 60, 70-year-old patients who tell you, I don't have a smartphone. I don't want a smartphone. I have a phone with with numbers, big numbers, and that's it. I don't want these things. So you need to have something that is really simple, and at the same time, you have like these technical guys who present you all kinds of gimmicks and things, and shiny apps that have different layers and different things, and you can swap back and forth, and you can look at all kinds of things, and it doesn't work. It just doesn't work because what you need is not a lot of information, and the techie guys, they always tend to give you a lot of information, and what you need is really a summary, because you want to have some sort of what is actually wrong, and I think we'll get there eventually. But right now, many of the solutions that are proposed and many of the things that we are getting are just too far away for patients to understand them. Or that's the alternative, that's my alternative theory or explanation. At some point, we will have a very natural feeling of technology. So it will be so normal to have a smartphone, to be able to work with apps, that this is going to be useful. But right now, there's a big trade-off. Like it's a trade-off, and it's a very big challenge to get these things really into clinical practice. And so I also agree, like it's unsolved right now.
Yeah, I know that WHO is very enthusiastic about all this kind of technological innovations, thinking that now we are going to save all people and solve all problems. But still, I loved in your presentation that you showed that there is still like this normal phone, and just calling might actually be helpful. Like someone contacts you weekly, maybe every second week, and also asks then, how are you doing? And is there something that you need at this very moment? And maybe we can solve this problem. So how do you feel about this kind of simple solution instead of very complex multi-layer gaming-based solutions, which are fun to develop, but usually fail after the piloting or after the project phase,
Yeah. That's true. It's something I learned. I have a good example at home. So we have so my wife, she's a palliative care doctor, and there is a system in Germany. It's called specialized ambulatory palliative care, and it's precisely what you are telling. There are patients who are included in this program, and they are just included. It doesn't mean that you have to go there. It doesn't mean that you have to do something. They just know that they can call, and they can receive help, very unbureaucratic, very simple. And at the same time, they are called every, I don't know, 2 weeks, 4 weeks. I don't know the exact dates, but they are called, and it's just a quick call. It's just like, how do you feel? Like, is everything okay? Do you have any problems? Can we do anything for you? And so it's a very simple system of people feeling safe, because safety is also one of the big aspects that we are really not sure what, like, are Parkinson's disease patients feeling safe, although they are falling, although they feel like it could get worse, although they have no access to care. My gut feeling would be they are not safe. We are looking at that. I don't know what would be the result of that, but I think they are not safe. I think they feel like someone taking care, and even if it's just a phone call, would be great. And in my clinical practice, yesterday I had a call from one of my patients, and he was just asking, because the problem he has is when he stands up, he feels like he's feeling dizzy, like not orthostatic dysregulation. It's pretty simple, autonomic failure. And so this guy was just calling to know if it's a problem or not. And the whole call was not longer than 5 minutes, and it reassured him to that everything was okay. And so I think that's a very simple system of telemedicine, of feedback, and of reassuring patients that everything is fine. And once there is a problem, they will call you, and you will have access so that things are not really getting worse, or you may even prevent getting them to hospital. So it's a very simple solution that could be implemented easily. Yeah.
That's I thank you for confirming this feeling that maybe we sometimes make things too complex. And I think there is another option also, which is very useful, is of course all kinds of wearables that we know, for example, from cardiac patients. And I hope that also those wearables that are developed for Parkinson's patients will also level up at some point and will become like little patches that you wear on your body, and not this kind of complicated things that you have to manage. And so so that this will also help to monitor the situation a little bit better. So there is a hope in technology, but maybe we invest into this kind of apps too much at this moment, and we should look more for best practices also from other areas. And it's because I think we are like in some ways, if you look what we are doing, we are inventing the wheel again and again, you know. But no, my final question is about quality of life, and you mentioned also depression, which is difficult to maybe detect also when you see the patient for a very short time. And we have had wonderful webinars with neurologists, nurses, and other professionals. And my question to you is that what quality of life, in your opinion, means actually?
That's a good one. I could refer about that like for hours. Let me give you just the most important parts for me. When we talk about quality of life today, we are talking about the PDQ. The PDQ is a mess, to be honest, because the PDQ, the Parkinson's Disease Questionnaire, has 39 items, and the only thing it asks is things like, how was your sleep? Have you been falling? Have you had problems with this? Have you had problems with that? So it's a health-related quality of life that it asks, and it completely neglects that patients may have quality of life because of something they actually have, like a resource that they are really, really having and that they are happy with, proud of, whatever, hobby, family, whatsoever. That's a big problem. It is. I think it like the BDI correlates with health-related quality of life. So the depression correlates with the health-related quality of life, and it must correlate, because the moment you feel like you have no joy in anything is when you are feeling so depressed, like your motor symptoms are so bad that you feel depressed. So it's a bit of a vicious circle. We are trying to look at holistic quality of life, and this is where this comes from. So the question is, what is actually maybe a determinant of good quality of life? And I'll give you another example. It's a very drastic example, but it's still, I think it makes the point clear. If you consider someone like Stephen Hawking, you all know that, like the physician, the physicist who died some years ago. So this guy, according to the PDQ, he should have like the highest values that you can think of, because, I mean, he was probably not sleeping well. He was wheelchair bound. He couldn't speak. He had a computer that was talking for him. But at the same time, you never have the feeling that this guy was really suffering that much. So he had an acceptable quality of life. So there's a discrepancy. He was having a brain that was working in an extraordinarily good way. He was able to write books. He was able to communicate. So he was having some resources. And the question is, what are we looking at? Are we looking at health-related quality of life? I agree. It's a mess in many patients. But if I think of many of my patients who are at home, they are embedded in a great working family. They are having access to physical therapy, to occupational therapy. It's not great. They are still restricted. But I think that quality of life isn't as bad as the PDQ would suggest. So the question, what is quality of life, is difficult to answer. It's also where to start, is like spiritual aspects, economic aspects, really important. Like people having the impression that because of the disease, they will not be able to support their family. They will be a burden to them. They will not support the kids. They will not be able to take care of their spouses, things like that. That's a big impact on quality of life that is not reflected in the PDQ, you know. And that's so again, it's very difficult, but to put it like to put it as short as possible, I think we still don't have the definition of quality of life that is needed to really get a holistic impression of what PD patients are actually feeling like.
Yeah, I think in a nutshell, it's like that. Not only ask what patients need, but also ask about what kind of resources they have at their disposal, and then maybe then we can help also them to use or those resources that are there in a way that the quality of life is perceived as a good one, and also that there is less this kind of depression, which is of course like can be related to socioeconomic aspects that you just mentioned, so or some other life aspects, not only to the health. So for this, I thank you very much for this very nice discussion and talk. Is there something that you feel that you still need to share with us, and so that you have the final word here?
Actually, I had the time to put forward our concept. I think it's the last thing, or the thing that I wanted to mention is that we in fact have as a neurologist, as a physician, we have to be aware of all the other professionals that are there, and it's not a bit of physiotherapy and a bit of this and that, but these are professionals. These are people that are trained for years, and so listen to them. That's the only thing I can tell my younger colleagues. Listen to them, use their expertise because they're good.
Thank you very much.